Welcome, everybody. Hi, this is me, Dr. Pravin Prasad from Nepal, welcoming you from a small speech regarding health insurance and clinical pharmacology to reflect the theme race, ethnicity, and socioeconomic influence in clinical pharmacology for this WSMD 2026. When we see the global pattern of medicine use, we see that the medicine use pattern has been increasing. However, the problem of inequity is still persistent. One of the reasons for this would be insurance coverages. We see that reimbursement decisions are directly influencing the prescribing practices in some part of the globe. In other part, when the insurance status is not active, there is a problem with the medication access as well as adherence. Study the impact of health insurance on drug development. It is seen that the countries which has a very good health insurance coverage has a very positive pharmaceutical innovation uptake. However, in countries where the health insurance coverage is very poor, as for example in the low middle income countries, the number of study being conducted is also very less. Around 4% of clinical trial globally is being conducted in LMICs. Because of this, the data being generated from the LMICs are also limited. Even if a country has a very good insurance policy, the insurance design itself could lead to some social inequalities. Patients with limited health insurance would face several problems like formal restrictions, prior authorization delays, and higher cost sharing for essential medicines. From pharmacological outcome, this could lead to subtherapeutic dosing, treatment discontinuation, and preventable drug-related morbidities. The set of problems in areas with poor health insurance coverage, as per LMICs, would be quite different, which would include increased risk of counterfeit medicines, irrational polypharmacy, and early discontinuation of the treatment. With this knowledge, I would like to just give a brief overview of Nepal's experience in health insurance. It was started around 10 years back, had some green flags as shown in the slide. Amid the green flags that we have for our Nepal health insurance policies, we do have some red flags in terms of coverage, equity, and financial protection. Because of all these red flags, what we can conclude is that population-specific pharmacology for Nepalese patients remain largely inaccessible. So it can be considered a privilege still for major part of the country. So with this, I would like to end my presentation today. And if there are any queries, please feel free to contact me. Thank you.